Hi, class. This is Dr. Weaver. I wanted to go ahead and create another voiceover. Our next topic will be male genital urinary system. All right, it's about 47 slides altogether. And so I'm going to start with, I think, slide 23, I believe. So let me go ahead and just start sharing. Remember, the rest of the information or the beginning of the information will be talked about in class. All right. It's about 1:30 in the morning. I said to myself that I would go ahead and do this um, tomorrow after class sometime, but I still figured I got some juice left in the or some gas left in the tank, and I figure I can go ahead and get this done. Shouldn't take too long though, because it's again it's 47 slides, and I'm starting at around slide 23. I figured I can get up to slide 22 in class, so works out very well. Anyway, so we're talking about again male genital urinary systems. All right. There are some questions that the examiner will ask the patient, along with rationales that are provided, and you can look at this on page 688 to 89. All right. So any sexual contact with a partner having an STI, which is of course sexually. Um, you know what? I forgot what STI. You know, we used to call it something else years ago. So I have to always kind of look up some of these definitions. So sexually transmitted infection, which really encompasses a variety of STDs, such as you can see here, gonorrhea, herpes, AIDS, chlamydia, venereal warts, as well as syphilis. And of course, take a look at those questions. They're quite related. When was this contact? Did you get the disease? How was it treated? And were there any complications and so forth? So you guys make sure you take a look at those questions. And also, again, take a look at the rationale as well. I don't know. I don't think this one actually provides any rationales, not for the STIs, but wherever it pertains, make sure you take a look at that. The next one we are looking at here is so additional history regarding infants and children, and this information can be found on page 689 to 690. Again, it does ask or provide you with some examiner questions questions to ask, as well as the rationale. For example, does your child have any problems urinating? And does his urine stream look straight? Any pain with urinating, crying, holding the genitals, UTIs, infections, and so forth. Age-appropriate questions. Has a child started toilet training, and how well is the child doing? Let's see if there's anything. One of the ones that, although make sure you guys read all of these questions, but the one that, of course, stands out to me, which I'm sure it would for you guys, especially those who are parents, is the inappropriate behavior question. Has anyone ever touched your penis or in between your legs and you did not want them to? So obviously, that is going to be a very relevant a question to ask, right? Um, it's basically it's a sexual screening for sexual abuse. So for prevention, we have to teach the child that it's not all right for someone to look at or touch their private his or her private parts while telling him it is a secret. Some adults, some sick adults, will tell the child, they want to touch them and don't tell anybody. And so this is all a part of that screening process. Naming 3 trusted adults will include someone outside the family. And so this is important since most molestation is by a parent. So yeah, so that's a big one that rings out to me. Also, one of the other questions is about wetting the bed at night. Questions you can ask because there is that possibility of nocturnal enuresis. This is involuntary urinating at night after the age of 5 or 6 years old. So, all right. So anyway, so make sure you take a look at these questions and if there are any related rationales to each one. All right, and this is the one for this slide here, rather, is for pre-adolescents as well as adults. And so let me kind of get here. So these questions are appropriate for this particular age population. And this information can be found on 690 to 91. And some of the examiner questions start off with a permission type of statement. Oftentimes, boys, we will say this. We will say this to the child or the pre-adolescent, adolescents. Oftentimes, boys your age experience and whatever we might say. And of course, this conveys that it is normal and all right to think or feel a certain way. All right. Now, we want to try the ubiquity approach. For example, when did you, right, rather than saying, do you? And of course, as it mentions here, this is a method that is less threatening because it implies that the topic is normal, is not some, it is unexceptional, right? Not something out of the ordinary, if you will. And of course, you should not be concerned if the child does not want to discuss sexuality with you, or they may not even want to respond to um, your offers for this information. So, but you can make sure that there's an open door policy so that in the future, if the child desires to come back and have this discussion with you, then we want to obviously make that possible. All right. Now, of course, I guess one of the bigger problems is that these children they tend to obtain information, often misinformation from the media, the internet. We know that everything on the internet is not appropriate, and also peers. How we listen to our friends when we were younger, right? But this occurs at an early age, and children can be very impressionable. So um, we just have to make sure that the information that we're providing of the child is more thoughtful and it is correct as possible, right? Um, all right, and continuing with pre-adolescents and adolescents. Now, around the age of 12 to 13, and sometimes earlier, boys will start to change and grow around the penis and also the scrotum. And we want to know what changes have you noticed as we have this discussion with the child. Um, and we also want to ask him if they ever seen a chart and pictures of normal growth patterns for boys. And of course, I think that's the SMAR, SMR chart. And it shows you these different stages of development. And that would be good to have handy as you have this discussion, just to give the child, a visual. All right. Um, And of course, questions, appropriate questions. Who can you talk to about your body changes and about sex information? How do these talks go? You want to evaluate how well this discussion goes for the child. What about sex education classes at school? Some offer it and some don't. What about parents? Is there a favorite teacher or doctor, minister, and so forth that would be easier for the child to have this discussion with? This information is also on page 690 to 91, so take a look. Um, and then, of course, around Um, I guess that's really about the same age, 12 to 13. So also boys around this age, they experience or they normally experience fluid coming out of the penis at night, and we call this nocturnal emissions or AKA wet dreams. And you want to know if they've ever had it. And of course, teenage boys they wonder if they're the only ones, that experience these things. It's like having an erection at some embarrassing times. They sometimes have sexual fantasies at this age, or they're masturbating, obviously. All right, and boys might also have thoughts about touching another boy's genitals, and of course wonder if they might be, homosexual and whatnot. So these are some of the questions to ask. If I didn't mention it, this information is on 690 to 91. Um, let's see. Uh, sexual- just want to see if I covered everything here. Keep in mind, a young boy may feel guilty about experiencing these things if not informed that they are normal, and perhaps it may pass. Who knows? Um, you also want to assess their level of knowledge because a lot of boys will not admit that they need more knowledge. And of course, we have to anticipate that even if they have some kind of knowledge, it may not be the correct knowledge. And so it would be very important to, talk to them about these things. All right. Um, Now, one of the things we also want to ask is if the child is dating, if it's someone who we refer to as being steady with, or have they had intercourse, and are you using condoms and whatnot? And so we always want to avoid the terms such as having sex. Because it is ambiguous, teens can take it to mean anything from foreplay to intercourse, and so we have to be very specific about how we ask these questions. All right. Then, of course, open the door. Is there anything you want to talk about? And just leave it open and see what they have to say. Kind of went ahead of myself on some of these, but also often boys your age have questions about sexual activity. Another question to ask: what questions do you have? How about things like birth control, sexually transmitted infections such as gonorrhea or herpes? Are you dating? I've talked about that already. Are you using birth controls? Raincoats? Well, that's it. Raincoats. That's one of the other term that they often called. You hear from a lot of young people, but you can say condoms. I think condoms are more appropriate and less unambiguous, or less ambiguous, I guess I should say. And also, what kind of birth control is the child using is another one. Of course, since we're talking about well, actually, we're talking about boys and girls. Well, technically for this one, more boys, but for girls and boys, of course, we want to be again a little more specific, I guess. Um, has a nurse or doctor ever taught you how to examine your own testicles to make sure that they're healthy? Because as you know, testicular cancer can be, an issue. Perhaps not as much for this age, but it is possible. And then also we want to ask questions like, has a child ever had a vaccination called um, Gardasil? And of course, Gardasil is a vaccine, an HPV vaccine. And I'm trying to think of the age. Uh, let's see. It's approved for ages 9 to 26. All right, so that's about the age range, if you will. And this information is also on page 690 to 91. And and has anyone ever touched your genitals and you did not approve of it? Another boy, an adult, even a relative, which relatives definitely pretty common, unfortunately. Sometimes that happens to teenagers, something we, will mention to the child, and that we must make them to understand that it's not your fault. I mean, and uh, and uh, and also make sure they know that they should inform another adult about it, and that would be important as well. Information can be found in the same place, 690 to 91. Right? And then we are looking at the aging adults. Really important questions to ask is, are you having any difficulty urinating? Has there been any hesitancy of straining, a weak force of a stream? Also dribbling as well as incomplete emptying of the bladder. Um, and of course, early symptoms of an enlarged prostate can be tolerated because that can be the cause. It could be a prostate issue. But the enlarging prostate early symptoms may be um, uh, minimal, if you will, and can also be tolerated. But later on, as the prostate encroaches on the urethra even more, then you have more dramatic symptoms such as hematuria, as well as a UTI, because you're not these patients are not actually emptying their bladder as well. Um, we also want to ask, are they leaking water or urine when they don't want to, and do you use a pad or tissue to catch urine in the underwear? And in essence, we're talking about incontinence, which is involuntary leaking of urine, which is possible with these patients with an enlarging prostate as well. Another important question is, do you get up at night to urinate? And so some important questions to ask is, what medications are you taking? What kind of fluids are you drinking in the evening? So, for example, some patients may be taking a diuretic medication at nighttime. Say if the medication was ordered twice a day or BID, what times are you taking it? Some may consider 9 in the morning and 9 at night, which is an inappropriate time. And so we want to make sure they are taking the medication at 9 in the morning and maybe 5 in the evening, even though that's not the traditional BID. But with diuretics, that would be an appropriate time, 9 and 5. Because otherwise, if you give it a 9 at night, these patients, especially given the duration of the drug, it can go well into the wee hours of the morning, and so the patient is just up and down. Sometimes, if these patients are drinking fluids such as coffee or alcohol, they also have like a diuretic effect in that it causes people to urinate quite a bit. And so you want to know about those things. And of course, as far as health promotion, teach them to not drink any of these things a few hours before going to bed. Also, there's fluid retention from mild heart failure. Varicose veins can produce nocturia because remember the fluids are pooling in your lower limbs, but then when you lie down in a recumbent position, fluid, it mobilizes is how we refer to it. In other words, that fluid, especially if it third spaces or goes into your tissue, it comes back into your vascular space and then returns to your heart. And then, of course, the left side of your heart at some point pushes that blood out, gets to your kidneys, and you start making a lot of urine. And of course, now you're up all night. So think about that as well with these patients. This information can be found on page 691 to 92. There are examiner and questions as well as the rationale. All right. And of course, as far as objective data, the other information was more for subjective, so this is objective data. As far as preparation, we want to position the male standing with the underwear down, and also we need to consider rather appropriate draping. Um, Now, concerns would be similar to those that the female would have during examination of the genitalia. Um, we want to take time to consider these feelings as well as explore our own feelings. If we had to have our genitals examined as well, not a very comfortable feeling because it's a very private situation for many of us. Um, so our demeanor, of course, it should be one of confidence and also relaxed. We shouldn't be all anxious and uncomfortable and that can make the patient uncomfortable as well. We want our touch to be more deliberate. It can't be a soft and or like a stroking type. Um, as a matter of fact, whenever we do begin to examine, these patients, we want to really begin with the back of the hand to the hand or you want to assess them with this part of the hand first, or when you begin to touch them, this part, and then you turn your hand over, and as you begin to assess them, which would be more appropriate. Um, Take a look at the equipment that would be needed in this case. All right. The first type of assessment we will employ is inspection, as well as palpation of the penis itself. All right, and take a look at the what we should see. All right. Skin normally looks wrinkled, hairless, and without any lesions. In the back of the penis, there's a dorsal vein that would be apparent. Um, some things that are really important here is if someone is not circumcised, we would want to ask the uncircumcised male to retract their foreskin, and not do it for them, but allow them to do it. Uh, Sometimes we may have to, especially if they don't have the manual dexterity to do it, but it should be done in a tender way. All right. You don't want to cause any undue discomfort. Sometimes when someone is not fully, or someone is not circumcised, they have what we call cheesy smegma that may be collected under the foreskin. And so after we inspect, the penis, we want to slide the foreskin back to the original position. Don't just leave it as it is. Also, as far as the urethral meatus, it should be positioned just centrally, right? When you think about the picture that I would have shown you earlier, because sometimes the urethra may be below or could be above instead of centrally. So, um, and hopefully I'll be able to show you that in class. We also want to compress anterior-posteriorly between the thumb and forefinger. Um, Now, the meatus of the flesh edge should appear pink, smooth, and also, of course, without discharge. All right. Now, starting on page 692, there are normal findings as well as abnormal findings, and so um, that would be very important for you to take a look at. All right. Some other abnormal findings as you inspect and palpate the penis is you're looking for inflammation. We're looking for nodules, or rather lesions. Could be in the form of nodules. There could be solitary ulcers like a chancre from a syphilis. There could be grouped vesicles or superficial ulcers. Think about your viral type of infections, such as herpes. Also, there can be wart like papules. And so just take a look at the different pictures that your book provides for you. All right. Um, Now, there is a condition wherein you cannot actually retract the foreskin, and they call it phimosis. It's a narrowed opening of the prepuce so that the foreskin cannot retract. All right. There's also another term called paraphimosis, and this is painful constriction of the glands by the retracted foreskin. So it would be a bit more impossible to retract the foreskin of those types of patients. And remember, I was telling you about the urethral meatus and how it is centrally located. This is where the male actually pees from the penis. You have a couple of terms called hypospadias and another called epispadias. The hypo means that the urethra is on the ventral or the front side location of the meatus, and of course the epispadias is on the dorsal location of the meatus, and so they are in different. They're not in the normal or the usual spots, if you will. All right. I'm not sure if your book actually has um, any pictures per se. If they do, perhaps they are in another chapter. Actually, let me see. Let's say chapter 25, penis abnormalities, 706. So if we get to those, or you guys can go ahead and just click on the link, and it should take you to the table, which will provide you hopefully with some pretty good examples. Uh, let's see, what else am I missing here? All right. Um, all right, I think that's about it there. All right. And so we continue with inspection and palpation of now the scrotum. All right, so we're moving down from the penis now down to the scrotum. And this information, the normal findings and abnormal findings, can be found on page 693 to 95. We want to inspect the scrotum, but as we inspect the scrotum, we want to have the patient to hold the penis out of the way to the side. Or we can also do the same, but if the male patient is able to do so, then allow them to hold the penis to the side as we take a look at the scrotum for any abnormalities, if you will. Um, but it also, remember I was telling you about using the back of the hand in some cases. If we have to hold the penis out of the way, use the back of the hand instead of the front of the hand. And so um, it's just a more appropriate way to examine the scrotum. We also want to palpate gently each scrotal half between the thumb and the first two fingers, because the scrotal area can be extremely tender. We'll also want to palpate each spermatic accord between the thumb and the forefinger. along its length from the epidermis up to the external inguinal ring. And so just take a look at the rest of this information. Um, there is a test that is actually performed as well. Um, Let me kind of back up a bit. Um, Now, it is not unusual for asymmetry to exist when looking at the scrotal area. So asymmetry is fairly normal. The left of scrotal is usually half um, lower than the right testicle, if you will, or scrotal area. So don't be surprised; it's not an abnormal finding. If someone has a scrotal swelling or edema, the skin may be pretty taut and also a pitting. It may be of a pitting edema. And you will see this particularly in conditions such as heart failure. The patient can have renal failure. You know, you're holding on to all this fluid, as well as some local inflammation. Remember, as far as inflammation, you see pain, swelling, redness, heat, and so forth. And also, we want to look for lesions as well. All right. Uh, let's see. What else can I tell you about here? Um, right. Now, the testes should feel normal. They're normally oval, firm, also rubbery, as well as smooth, and equal bilaterally. Right? And they're freely movable as well, and they are slightly tender to moderate pressure. So we have to really be careful about how much we're palpating the area. The Each epididymis normally feels discrete. It's softer than the testes, smooth and also non-tender. All right. There is one that I'm looking for. Now, as far as the spermatic cord is concerned, if the cord is thickened, that is an abnormal finding. Sometimes it can be soft, swollen, and torturous. The cord can be torturous. It's when we talk about something as torturous, it's how can I say it? Almost like an entanglement, if you will, right? It's almost like an entanglement. Um, Sometimes we have like, um, what do you call it? We have intestines, for example, that can be torturous, right? Um, it just doesn't have a normal, flow, if you will. It's kind of hard to explain, but um, yeah, but wanted to when a testicle is torturous, it's kind of twisting. I guess is another way to put it. It's twisting, and so it doesn't allow adequate blood flow, and that's one of the reasons why when a tube, whichever whatever it is, but be that a GI or in this case the sexual organs, if the vasculature is torturous, then it's twisted, and the blood just cannot flow as easily in twisted type of those twisted kind of structures, if you will. It's kind of the best way to explain it. Anyway, let's see. We're also looking to see if there's a mass. We want to determine the location, the size, the shape, as well as the ability to reduce, the mass. Say if it's a hernia, can we reduce it? Can we push it back into the the scrotal ring, if you will. Why did I do that? There's something else I want to. Um, yeah. All right. So you can see here where it talks about perform a transillumination if a mass or swelling is detected. It will look different depending on whether it is a mass, a solid mass versus just edema, a fluid, if you will. Um, what we want to do is we want to make the room dark, and then we shine a strong flashlight from behind the scrotal contents. Um, if it is a solid scrotal contents, um, it won't trans illuminate, so you won't be able to see through it, right? Now, if it was fluid, such as edema, it does trans illuminate, and it shows like a red glow. It could be a hydrocele or spermatocele. Solid tissue and blood, it just doesn't trans illuminate. You just can't see through it. So, for example, if it's a hernia, epididymitis, or a tumor, it won't trans illuminate. You won't be able to see that characteristic red glow. All right. So that's what we mean by trans illumination. Right. And here we just talk about inspecting and palpating a patient for a possible hernia. We inspect the inguinal region for bulges as the person stands and strains down. um, and normally, of course, obviously none is present. Now, there's a technique, of course, to use when performing this assessment. So for the right side, we ask the male patient to shift his weight onto the left leg. All right. And so what we're looking for is we're checking for nerves, arteries, veins, or an empty space as well as we're assessing lymphatics as well. All right. We also palpate the femoral area for a bulge, and of course, obviously, we don't want to palpate anything. Um, Hopefully, they won't have um, a bulge, meaning a hernia as well. And this information can be found on page 695, the normal as well as the abnormal findings. All right. Bulge. Let's see. Now, usually a hernia can be present, but easily reduced and appear only with an increase in intra-abdominal pressure. So when we strain, we're creating this intra-abdominal pressure, and that's what actually would reveal the hernia. But it can be reduced or pushed back into its proper place. Now, palpable hernia mass, it tends to bump the fingertip or pushes against the side of the finger. And so your book has some information on that, table 25.7, page 711, and it talks about the inguinal and femoral hernias. All right. Right. And your book just tells you how to perform that assessment. If you're assessing the right scrotal, then they should shift weight to the left leg. And if you're assessing the left scrotal, then they should shift weight to the unexamined leg. All right. And it makes it easier to perform this assessment. All right. Right. Now, your book talks about, as far as that acronym that I just mentioned, naval. So you place your right hand upright on the man's right upper thigh, and of course we remember the acronym naval. So remember that's nerve, artery, vein, empty space, and lymphatics. So in other words, we locate the femoral artery, um, pulse with the index finger. Then there's the empty space. The empty space will be under the fourth finger. Then we ask the man to bear down and palpate the femoral area for that bulge, which could be that hernia. Normally, you feel nothing. Change sides using the left hand for the man's left side, and so we just switch to the other um, leg. Um, as far as lymph nodes are concerned, we palpate the horizontal chain along the groin inferior to the inguinal ligament and the vertical chain along the upper inner thigh. And what we are looking, well, what we don't want to have is an enlarged lymph nodes, a hard, matted, fixed nodes, because that can signify an issue. Painful lymph nodes would also be another issue as well. All right. Lymph nodes should be soft, discrete, and also movable, right? Not fixed. Otherwise, we're talking about an abnormality that should be investigated further. All right. And these are just some of what I was talking about. You have the external inguinal ring, and this is what I'm saying. You place that index finger in the inguinal ring, and then you have them bear down, and you might feel the intestine bump up against the finger. Here is both. All right. You guys won't be doing that. So, I mean, unless you're a nurse practitioner, you work in the doctor's office or something like that, but, still got to teach it right. Let's see, I talked about this already. All right. And this is the testicular self-examination here. All right. We want to encourage self-care by teaching every male from the age of 13 to 14 years of age to adulthood how to examine their own testicles. Early detection, of course, of cancer can enhance um, can cancer enhance if a male is familiar with the normal consistency. So if they know how to examine themselves and know what it thinks, how they should be, how they should feel, and what have you, then they could detect cancer a whole lot earlier, and it can, of course, we can employ the proper treatments and give the patient a much better a chance of survival, right? Now, points to include during the health teaching, take a look, the TSE, T for timing. We can do it this, or we want to teach them to do it once a month, especially if they're, of course, the S stands for in the shower, where the warm water relaxes the scrotal sac, right? Because we don't want the testicles to and the scrotal sac to retract. It's hard to really feel for any abnormalities, but we want it more relaxed so that we can get a really good feel for what's happening, in that area. And then, of course, we examine, we check for and report any abnormalities immediately, um, and what have you. So, the overall incidence of testicular cancer is pretty rare, right? But you could be a part of the rare group. But it accounts for about 8,000 new cases annually, which is not a great deal, I suppose. But it does occur most often between the ages of 15 and 35. So you can see why it would be really important to begin teaching these young boys about these things, just before that 15th birthday. Um, but it is associated with the history of cryptorchidism and other factors as well. And you can find that information on page 709 as well. Right. The good thing about testicular cancer, although not common, but when it's detected early, and of course, you know, being detected early, you can start treatment before metastasis of the cancer occurs, and of course, the cure rate, same with prostate cancer. If you detect it early, it's like 100% a cure rate. Right. It is early detection, obviously, is going to be the goal. All right. All right, and now we are looking at um, kind of got behind on this. We're looking at we're doing an assessment of the urinary function. We are looking at the color of the urine. Also, what is the pH and the specific gravity? How concentrated, in other words, is the urine? That's specific gravity. And then, of course, we want to know how the kidneys are doing, since the kidneys and the ureters and the bladder are all connected. We want to know what is the function of the kidney. Um, in other words, what is the creatinine level? Oftentimes we look at BUN and creatinine, but the creatinine is more specific to the kidneys. And of course, creatinine is the end product of muscle metabolism, whereas the BUN is the end product of protein metabolism. All right, but although we do check both, creatinine will be what is most significant here. That information is on 697. All right. Now, usually the urine color should be pale yellow to amber, and that's what you document in your notes. And it is caused by what we call urochrome pigments. And you don't have to know that, but just an FYI. The normal urine is again is clear, and it is slightly more acidic. The pH range should be 4.5 4.5 to 8. And of course, this minimizes the ability of a microorganisms to survive, right? The more alkaline the urine gets, then they can be susceptible to infection. The urine-specific gravity, it measures the concentration of the urine, and if it's very diluted, well, the range is let's see, 1.003 3, uh, and that's very diluted urine, and all the way to concentrated urine, which is 1.030 or greater. So it means that the urine is more concentrated. Um, if there is protein, it should be very little. It should be no glucose. Sometimes patients, when they have diabetes, especially new onset, they don't know anything about it, but you might see glucose in the urine, and so that can be telling, right, revealing. There should also be fewer than 5 red blood cells in the urine, and white blood cells can be present as well. If the urine is cloudy, it does suggest that there are white blood cells, bacteria, and casts in the urine, and so we may be looking at an infection. There are also certain drugs that we have to be concerned about, and take a look at table 25.2 about some of these foods or drugs that can change the color of the urine, like pyridium. Pyridium is a kind of a urological analgesic. When patients have urinary tract infections and it's painful, then we place them on pyridium, and it turns the urine a characteristic orange color. Proteinuria can indicate damage to the glomerula, um, um, or to the nephrons, I should say, especially in cases like hypertension, or it can be diabetes and those kind of things. Glycosuria, the urea, meaning glucose in the urine. Again, it can suggest increase in blood glucose levels, such as seen in diabetes. If someone has an increase in white blood cells, it can mean that they have a UTI. An increase in red blood cells can also occur with UTIs. And then also there's glomerulonephritis, which is an inflammation of the glomerula and the nephrons. There's also renal stones, or something we call renal calculi, trauma or cancer as well. Um, and so these are the things that the urine-specific gravity and the pH, all that can be altered a bit in these types of conditions. But these are just some of the abnormal findings that you'll see in the kidneys. Um, you should also note that um, the normal BUN is between 10 and 20 milligrams per deciliter of blood, and the creatinine is between zero point 0.7 to 1.5 milligrams per deciliter. All right. And as I said, we normally measure kidney function by looking at the creatinine levels, again, the end product of muscle metabolism. And this is pretty constant from day to day as long as the kidneys are doing their jobs. And as I also mentioned, the BUN is a measure of, or end product of protein metabolism, and it can rise if someone is having or experiencing dehydration, or if there's an increase in protein intake. I mean, you eat a lot of meat or other foods that are high in protein, it can also increase your BUN levels. Now, you should also know that proteins can really put a strain on the kidneys. And so sometimes when patients, when their kidneys are more or less dysfunctional or they're having some issues, sometimes we minimize the amount of protein in the diet so as not to overstrain the kidneys. So, that's just a little bit of information for you guys to think about. All right. And as I told you also, the BUN, it does rise in dysfunctional kidneys, but it's not as specific as creatinine. All right. And you guys will also hear this term called, well, when we measure the creatinine, well, creatinine actually measures the glomerular filtration rate, or GFR. G as in girl, F as in Frank, R as in Romeo. Now, the GFR is the product of filtration pressure in the glomeruli, which is normally about 125 milliliters per minute. And so when you look at the GFR, you look at like a chart. Um, if you're seeing a number of 125, that means that you're excreting that waste at a normal rate. But of course, as that rate decreases, say you get down to 30 milliliters per minute, it just means that you're not excreting the waste products as well as much. And of course, what it is doing is it is building up within your system, which is not a good thing. All right. And so that's how we look at some of the our CKD, or chronic kidney disease, patients. All right. It's how we determine the severity of their renal dysfunction. Now, when the GFR is decreased by half, with let's say around 60, the serum creatinine levels are going to double. Right. And this is not good. Um, so the patient's kidneys, they may require hemodialysis at some point, or peritoneal dialysis, whichever one, patient preference, if you will. All right, let's look at the developmental competence of children. Let's see if there's anything that stands out here. This is something that's good to know. Perform this procedure right after abdominal examination. You could be testing on things like that. Preschool age to young school age child of 3 to 8 years of age, leave the underpants on until just before the examination. Those are questions that we could ask you. Um, Now, if someone is older, school age child or adolescent, we offer an extra drape because they're more modest, as with an adult, um, and reassure the child and parents of normal findings. So as you're talking to them, as you're going through the assessment, you're letting them know that what you're finding that is normal. It's rather reassuring, if you will. And so look at what we are assessing. We're inspecting the penis and the scrotum. We're palpating the scrotum and testes, and also inspecting, palpating the inguinal area for a bulge. These young kids, they are lifting weights, and so they can develop a hernia. So really important to evaluate. This information can be found on page 698 to 700. All right. As far as adolescents are concerned, they show a wide variation rather, in normal development of the genitals. And we use the SMAR chart to note that development, that growth, right? It looks at enlargement of testes and scrotum. It also takes into account pubic hair growth, darkening of the scrotal color, roughening rugae of the scrotal skin, also increase in penile length and width. We're looking at axillary hair. And of course, we want to be familiar with the normal sequence of growth. And so this SMAR chart is a good way to know if things are looking um, more normal. All right. Um, all right. That's all I'll say about that. And then there's the older adult or the aged adult, and take a look at what you would normally note here. These findings would be normal. All right. Um, let's see. Scrotal scan may become excoriated if a man continually sits on it. Um, all right. This information is also on page 700. All right. Now, something to keep in mind too is there's a condition called male hypogonadism, and this is just basically a reduction or deficiency in testosterone. And it does occur in about 40% of men after the age of 45. And it may be present or we may think it's, depression, fatigue, loss of muscle mass or strength. There can also be a decrease in their desire to have sex or a decrease in libido. Now, although these symptoms occur also with other conditions such as obesity, diabetes, and metabolic syndrome, you have to make the distinction. Is it one thing or the other? Is it due to the height, the low testosterone levels, or is it due to these other disease processes? All right. Um, let's see what else. And then there's the urine color and discoloration. There's a range of colors that are associated with specific conditions, and so this would inform us as to what might be actually going on with the patient. For example, blood in the urine, if the color is red, it can be due to blood in the urine, as I mentioned, nephritis or cystitis. It can be cancer of the prostate as well as the bladder. And especially following if there was a patient had like a TURP or a prostatectomy, removal of the prostate, you would possibly see red. As in bleeding. Now, if the urine is cloudy, let me actually show you guys this what this would look like. Should be pretty easy to find. Hopefully you'll be able to see this chart pretty good. I think I can blow it up a bit. Yeah, I think I can. Yeah, there you go. So check it out. So if it's cloudy, it can be urinary tract infection. It could be kidney stones. If it is pale yellow, clear watery with excess liquids, or it could be acute viral hepatitis or cirrhosis, right? So just take a look at this. Take a look at this one. Um, uh, oh, I can move it. Yeah. Well, let me do this. All right. So take a look at the orange. Medication side effect. It could be rifampin, which we can use to treat meningitis. Um, Also, peridium. That turns the urine orange. Warfarin, or warfarin, that's what they call it as well, warfarin, Coumadin. It could be due to the fact that somebody might be bleeding. Some foods or food dyes, laxatives even, dehydration, and also jaundice. So just take a look at this information, and it just gives you an idea, at least, of the possibilities of what the patient might be experiencing. All right, that's table 25 too. How did I get to that one? All right. Also, vitamins. Think about the vitamins that we're taking. And also can be due to contrast dyes during surgery or diagnostic procedures. All right, so just keep those things in mind. All right. And again, that information is on page 702. All right. Take a look at some of the urinary problems in male genital lesions. So the urinary problems, we're talking about urethritis. So essentially, there's a discharge coming from the urethra in the male, and it's burning. It causes burning upon urination. There's also renal calculi, which is a stone in the kidneys. Then there's acute urinary retention and urinary tract infection. Just the retention alone can cause an infection because that urine is not freely just flowing out of the bladder, and so it's staying stagnant where bacterial growth can thrive. And then there's the urethral stricture, where the urethra is there's like a constriction, if you will, maybe due to some inflammation or something along those lines. This information, by the way, is on page 703 to 705. Look up the genital lesions, the tinea cruris, herpes, syphilitic chancre, as well as carcinoma. Your book does provide some of um, the abnormal findings that you would want to just take a look at. All right. Now, as far as renal calculi, you got these different stones that the patient may have. They can be calcium oxalate. They can be of the uric acid variety. And what happens is they form in the kidney tubules, and then they begin to move and become more urgent when they pass into the ureter. Those are the two tubes coming from the kidneys into the bladder. All right. They could become lodged, where they just can't move, right? But they're also blocking the flow of urine from the kidneys into the bladder. And so when you have that obstruction, the urine itself, the volume of it builds up into the kidneys. And this is what we refer to as a hydronephrosis, basically fluid on the kidneys. Right? This caused abrupt or severe flank pain with radiation to the groin or abdomen. These patients may also experience nausea and vomiting. They may be restless. The pain is excruciating, right? There may also be gross or microscopic hematuria. May not see it, or it can be gross. It can, you'll have quite a bit of blood in the urine because the the stones are kind of jagged, right? And as they are moving throughout the urinary system, they're scraping against the walls of the or the lining of the ureters and the kidneys itself, right? And of course that causes trauma. And of course this is when you'll see blood in the urine. Actually, there's a great illustration in your book here, right? So um, these are the stones here, and if one gets lodged off into the ureter, all right, then the flow of urine that is produced here won't be able to travel, well, reach, or rather, I guess I can say, drain into the ureters, down into the bladder. So that can be a problem. And then you just have this increase in urine here. Um, and again, that can be a problem. Let's see. All right. Let's see. What else can I tell you? Yeah, as far as that stricture is concerned, urethral stricture, um, it can be due to like a urethral injury, which of course with an injury you get the inflammation and so forth, and the tissue more or less changes a bit, and it can make it difficult for urine to flow. All right. Right. Now, when we talked about the acute urinary retention or urinary tract infection, this is just basically the inability to pass urine. Um, and of course, it will cause the bladder to become distended, which will, of course, compresses on nerves, and that will cause the lower abdominal pain. This is common in older men due to a bladder outlet obstruction from BPH, or benign prostatic hypertrophy of basically of the prostate. This can, of course, cause UTIs due to the fact that the urine becomes more static and it loses that turbulent flow, right? Um, or causes more of a turbulent flow because it just can't drain very well, from the bladder through the urethra and then out into, when someone is able to urinate. You will see this more so in men who are greater than or equal to 60 years of age. And of course, they may complain about dysuria or painful urination. They may have frequency, going to the bathroom very often. They may feel the urge to urinate. They may also get up quite a bit at night to urinate. They may complain of suprapubic pain of the suprapubic area. And also they may experience some hematuria, possibly a fever. And so antibiotics and addressing the underlying issue would be appropriate here. Uh-oh. Um, let's see. Actually, I lost my space. Why did I do that? Got to get back to my space here. All right. Yeah, I don't know why I went to that one a little too soon, I think. So just take a look at this piece of information, and then we have penile abnormalities as well. These are some of the things I was talking about here, like the phimosis, paraphimosis, where you can't retract the foreskin. Priapism is when you have when males have an erection that and it stays like that. Um, it doesn't, it's very painful, right? You see it a lot in your sickle cell patients where when that blood flows into the penis and then the sickling causes like an obstruction and the blood cannot move out of the penis, and of course it stays erected. And so that can be a very painful situation. Um, Right. So it does cause it's very prolonged, painful erection of the penis, and without any kind of sexual stimulation, of course. And of course, it's not even relieved by sexual intercourse or masturbation. It can last about 4 hours or longer, and it can actually cause ischemia to the penis. It can also cause erectile dysfunction and also fibrosis of the penile tissue. Um, Now, this is it can be due. Um, it can occur due to rare side effects from drugs for erectile dysfunction, such as Cialis or Viagra. Also, street drugs can cause this issue as well. Sickle cell, as I mentioned to you. Also, when patients have leukemia, in which there's an excessive amount of white blood cells that produces engorgement within the penis. And so that can also result in that as well. Um, it can also be due to spinal cord injuries when the autonomic nervous system dysfunction occurs. And so just a variety of things can cause this. Now, I talked about the phimosis and the paraphimosis, so take a look at your book about that. You also have a condition called Peyronie disease, and this is a hard non-tender subcutaneous plaques on the dorsal and lateral surface that is palpated by stretching the penis. And it may be single or multiple, and also asymmetric. All right. And it is associated with painful bending of the penis during an erection. I mean, the penis actually bends, right? It can occur after the age of 45, and it can be due to trauma to the penis, resulting um, with a resulting scar or deformity, even. Um, and often the penis doesn't work as well at times. But it's more common also in men with diabetes and also gout. All right, so those are some of the penile issues that you might see. When I talked about the hypospadias and epispadias, this is when the urethra is not centrally located as it normally is. And that information is on page 705. And then, of course, you have all these different conditions as far as scrotal abnormalities, absent testes or kidism, small testes, testicular torsion. Um, you have epididymitis and so forth. So just take a look at the rest of this information here. And, you know, as I always tell you guys, still read through it, and this particular section actually gives you subjective, objective, and assessment findings. Um, and so it would be good just to read through it. And if there's anything specific that you really need to place more focus on, then I can provide that for you all. Let's see. Yeah, they talk about in your book in table 25.6, you have the absent testes, cryptorchidism. You have the small testes, testicular torsion. There's epididymitis, or inflammation of the epididymis, varicose, um, spermatocele as well, early testicular tumor, and so forth. So the whole list of conditions are here noted in table 25.6. So just take a quick read of this information, kind of skim through it. Unless I give you something more specific in a focus sheet, then you can focus a little more on those areas. All right. And then, of course, there is the hernias. Take a look in your book, table 25.7. It talks about the inguinal and femoral hernias. It gives you an example of indirect inguinal hernias, direct, and also femoral hernias. And so just take a look at that information. It tells you about the course of the disease, the clinical symptoms and signs, frequency, and also cause. And so, you can skim that information as well. And then, of course, we reach the end, which is the summary checklist. And so we are inspecting and palpating the penis. We're doing the same with the scrotum. If a mass exists or edema, we want to try to transilluminate it. Remember, it would be like a bright red color. We're also palpating for inguinal hernias. and also palpating inguinal lymph nodes, and we know how lymph nodes should feel, how they should, how they appear normally, and that information, of course, is on page 705, just your checklist. And folks, that's about it. So this one was about an hour and 15 minutes, so not as bad. Um, And that is about it. I appreciate you guys tuning in to this presentation, and I will go ahead and end this. And I hope you find it helpful. Thank you so much.